Hello and welcome to Kauai Health's bi-weekly webinar. Today is Thursday, September 23rd, and my name is Deborah Volleson. I am the Director of Community Engagement. Our CEO, Gary Herbst, who's normally sitting next to me, cannot be with us today, but I have two of his vice presidents that are going to be joining us and filling in. I want to remind everybody that these sessions are to keep you up to date on what is happening around Kauai Health, our campuses and our services. And so today I'm really excited. We're bringing in Dan Elaine, our Vice President of Cardiac and Surgical Services, and Ryan Gates, our Vice President of Population Health. We're going to cover all of the questions that were sent in, and we also have our chat lines open if you want to send us a question during the live event. Thank you again for joining us, and I hope you leave this session feeling more informed than you came with. We will post this webinar on our Community Engagement Facebook page and also on Kauai Health/COVID/frequently asked questions on the website. So I am going to go behind the camera and welcome Dan Elaine and Ryan Gates.
Thanks for having us.
Yeah, Dan,
excited to be here.
You joined us a couple of weeks ago and you are back today. So thank you.
Had so much fun. Thank you for inviting me back.
Well, these are fun.
Can you see me okay?
Yeah.
Okay,
yes.
I'm on the screen.
Yes.
Because I want to make sure we're distanced here. Okay.
And Ryan, welcome. Before we get started though, I want to ask you, what is population health?
Well, I'm obviously doing a miserable job with the worldwide pandemic, but population health is really a movement within healthcare to really consider the holistic needs of our community and the patients that we serve, which includes their family, their social issues, including their healthcare issues. And so Kauai Health's leadership took it upon themselves to create the Population Health Division within our organization to embark on that endeavor.
Okay, well thank you. Good to have you.
It's good to be here.
Okay, Dan, we're going to start with the numbers. So let's start. Positive cases in Tulare County.
So this is hot off the press as of yesterday, actually. So truly, it's not hot off the press, but it is.
It's warm.
It's warm. Lukewarm. So as I don't want to get the numbers wrong, so I'll be reading some of the numbers rather than looking straight at our guests out there in the internet land. But one of the things, just to put this into perspective, from the onset of COVID pandemic in Tulare County, we've reported a total case number count of 60,575 patients as of September 22nd. So when we start breaking these down, the active COVID cases that we have in the county today are 3,552, which is actually down from 169 cases that was reported in September of 15 in their report from the Tulare County. What I look at is the 7-day average. So I'm looking at average of new cases per 100,000 population. So that kind of normalizes it based on the population based in all the counties. So we are at 48.7, which is up 7.3 cases from September 15th. However, the positivity rate, which is what I monitor very closely, we're at 9.5%, or we're down by 0.8 of a percent, almost 1%.
Okay, I'm going to ask you to go back and try to remember back when we were in the tier system. Remember when we were in the tier system, did we have to be at how many new cases per 100,000 to get out of that?
I think it was 7 or less
per
100,000. So we would be at the top tier. So highest level of restriction is where we would be today, and we would have a long road to get to the level that we were at, I would say this past summer before the surge started coming up at us greatly with the Delta variant.
Right, okay. So how many positive cases do we currently have in the hospital?
As of today, 108 total patients. Okay. So again, trending down, because yesterday when I first put this number together, we were like at 112 or 114. So I look for the slight trends downward as a positive trend that I think we're at the peak and we may be starting down. And I'll inject this right now because prior to coming over here, there's an advisory bulletin that comes out from the, it touches on all the healthcare areas, and one of those, it was titled, "Is the Delta variant peaked and are we seeing it go down?" So the modeling numbers, and I know, Deborah, you've asked me this because I have my crystal ball, and it was a modeling program, and because of all the variants and all the changes, they could no longer keep up with it. But I believe it's Johns Hopkins, and the advisory bulletin said in one study, they believe that we're at the top and we're starting to trend down. However, they're also saying, as a caveat, remember that there are many states that are going to start going into the winter season. And as we go into the winter season, people come inside, and there's closer proximity for everybody. And as a result, we may have an increase in some of the states across the United States. But I think and I believe that we are going down slightly. Slowly, but we are going down, and it would probably be back to where we were in the spring, late spring. It's probably going to take us until 2022, maybe of March of 2022, to get to those numbers. But it certainly, I believe it's going in the right direction today.
Yeah, well, I put a lot of value into what you say, Dan, because, and I've said this a couple of times on the webinar, maybe last year, you kept saying things were going to happen, and I kept saying, oh, that can't be true, yet it happened. So, you know, I know you're watching your software and all of your, and when you say crystal ball, I really do, you know, put a lot into that, because you were right all year last year. So not that I'm going to hold you accountable for what you say right now, but I am believing it.
Oh,
Okay.
you remember that crazy 8-ball?
Yeah.
You shake it up, turn it over.
Yeah.
Yeah.
Okay. Yeah. All right. So how many are in the ICU, and how many empty beds do we have in our ICU?
So the ICU census today is actually at 17. And we have 41 ICU beds in our organization, and they're split between 2 units. So we congregate the COVID patients in one of the ICUs. So 17 out of 21 patients are diagnosed with COVID infection. 13 of those are on ventilators. So that leaves us 37 occupied beds in our ICU with a total capacity of 41. So we have four available beds today.
Okay. And then what about our employees?
As of, I believe it was this morning, I looked at some numbers, 68 employees are either positive for COVID or they're being ruled out. And then we also have 23 that are newly reported that we're tracking. So they're, as we would say, our PUIs, are persons under investigation, the old terminology as we started the pandemic. And based on our historical positivity rate, out of those 23, we anticipate that maybe 3 or 4 will turn positive. So our number may go up to 72, or it may stay at 68 or drop below. It depends on how quickly they're recovering and returning back to work.
Okay. And what about our census, our overall hospital census?
Overall hospital census is 380 out of 435 available beds, licensed beds in the acute care medical center. So downtown Kauai Health Main Hospital, 435 beds. Now keep in mind that it's not just adult beds that we're counting. We're also counting maternal child beds. So the postpartum beds are in there, the NICU beds are in there. So there's pediatric beds as well. And if you can recall back when we were hitting the 170 range, we actually did convert our NICU over to an adult unit. So we worked very closely with Valley Children's to take our most critically ill children up there so we would have the capacity. So when we report licensed beds, it's all those beds. It's adult med surg, it's critical care, as well as postpartum, mother-baby, the labor and delivery side for mother-baby, plus the pediatrics and the NICU.
Okay, thank you, Dan. So you mentioned that the numbers are declining. So how far or how low do they have to go before you make the decision to expand our elective surgeries?
Well, it depends on my cohorts in the section chief meeting. Ryan is one of those. When I look at the ability to expand or to come up off of our cap of 3, which we have today, and I'm talking emergent, urgent patients that we will schedule for surgery. Those are the people that could have a worsening outcome or a prolonged recovery or a prolonged, should we say, disease process that worsens their ability for recovery. Those are the ones we're allowing in to our surgery today. We still do very simple outpatient surgeries. If we know 99.99% that they're going to be discharged, we will do those surgeries. But if there's a suggestion that you're going to be admitted, we cap it at 3 today. So what do I look at when I make a recommendation to the section chiefs? It's time to start relaxing some of the restrictions. We take a look at our bed capacity. How quickly are we able to take care of those patients who are holding in the emergency department? You know, right now it's from 30 to 60 patients that could be holding, depending on the day of the week. That means they're holding from the last evening to this morning for beds to start opening up. So that's one of the factors I look at is where's the ED at, where's the census? How quickly can we turn over the beds so we discharge and readmit another bed or another patient to our beds? The other is I looked at, and I already mentioned, is the positivity rate. Not only the positivity rate in Tulare County, but I'm looking at the state positivity rate. Now the state positivity rate, I believe the last time I looked was yesterday, it was 1.9%. That's very good. But I also have to remind everybody that's watching us today is that's taking into some areas, taking into consideration the areas on the coast. So LA, San Diego, San Francisco, there are some areas that are highly populated, but their vaccination rates are very high. You know, I'm a believer that the vaccine is a factor in reducing the ability to have or acquire the breakthrough infection of the Delta virus. It is helping, it is making a difference. So again, I said our positivity rate is 9.5%. If we would get around 5% positivity rate, and we would get a admission rate of, we're at 48.7. If we were probably in half, like 24, and I was seeing every morning a occupancy capacity ratio where we may have 20 med-surg beds available in the morning, then I would say it's probably time to start considering. Now I'm optimistic. I tend to be optimistic. And I'm saying probably mid-October we may be back to opening up more available capacity in the OR for admissions. Don't hold me to it.
Yeah.
But that's kind of what I'm predicting. So those are the things I'm looking at, is bed capacity, and the most important thing, staffing. Where are we with our staffing? So staffing, bed capacity, ED, surge, ED holding, and positivity rate, and the number of new cases per 100,000 in Tulare County.
So just explain what OR means.
Operating room, surgery.
Yeah.
Okay.
Okay, perfect. All right, so Ryan, the September 30th deadline that has been looming over us is quickly approaching. We are 7 days away from that. So how many of Cahuilla Health staff members have received the vaccination?
So out of the roughly 5,100, now we also have a big vacancy rate in terms of over 500 open positions that we're recruiting for, so the staffing
Is that included
portion.
in the 5,100?
I don't know exactly if that 5,100 included posted positions or filled.
Okay.
So I'm sorry, I don't have that level of detail, but we are roughly a 5,100 employee organization. 3,548 have submitted their documentation for vaccination. Now, and then 720, I'm going to get ahead of you on the questions, have submitted either religious or medical exemption. So depending on what number, that leaves about 830 or so. How many of that are the 500 vacancies versus how many of those are actually, currently employed, lacking either a declination form on file or documentation of their vaccine status? leaves us, several hundred employees. Now, remember that the vaccination, depending on which product you choose, Pfizer, Moderna, or Janssen, are a 2-dose series, if not the Johnson, which is 1 dose. But so the vast majority of people do receive the 2-dose series. Those are 21 or 28 days in 2 separate doses. And so we know there are many employees in the process of becoming fully vaccinated and won't be able to submit their documentation until they receive that 2nd dose. And so within that mix of, unknown status are those significant, we're willing, hoping that a significant percentage of those are obviously in the process of becoming fully vaccinated.
Okay, so explain to me, is there a difference between an exemption and a declination?
So we use the term declination. We're simply referring to the religious or medical exemption that the state allows for declining the COVID vaccine, whether it be, again, religious or medical exemption or declination. So no one is really exempt from the requirement, but you can decline based on those 2 allowances from the state.
So right now, the state mandate, we actually have employees who do not work or enter or move around in a clinical setting. So those employees were not required to do surveillance testing, correct?
Right. So there's two mandates, right, that came out, one right after the other. And so one is, which came out first, was the mandated testing of all unvaccinated employees who work in direct patient care areas. And so that's the first mandate that came out. So within that, correct, for people work in the finance building, they never step foot in the acute care hospital. They never interact with a patient. So they are exempt from that serial testing requirement. Versus those that work in the acute medical center have to test twice a week, and then the outpatient areas, if they're interact with patients, have to test once a week. So that's the state mandate for unvaccinated employees. Within a few days of that mandate came the vaccine mandate. And so that mandated all healthcare personnel in the state of California as a condition of employment to be vaccinated or have a declination form on file.
Okay, so on September 30th,
Correct.
If we still have employees who have not started the vaccine nor have turned in a declination,
Yep.
What happens?
It's considered a voluntary resignation.
Okay.
And that's not, again, our determination. This is a state requirement as a condition of employment in the healthcare industry in the state of California.
So
It's
I'm
not a CWIA Health decision.
Okay, so I'm asked often, so can CWIA Delta stand up against that mandate? Can we decide as an organization that we're going to say no, we're not going to require that of our employees?
Certainly, we would stand to lose our licensure as a hospital, stand our fines and the inability to bill for our services. So it's a nuclear option. And we did talk to our, the State Hospital Association and other organizations in terms of what the stance was, and there was simply no associations willing to pick that battle with the state.
Right.
So we would be standing alone in that.
So on 9/30, our unvaccinated staff who've turned in the declination form, they will still be working with patients. They will just be doing surveillance testing.
Correct, just as if they always have been, even before the vaccine was available. They'd be wearing the necessary protective equipment, the N95 masks and gloves and everything else that we do to protect both the patient and the employee.
Okay, so let's turn from the state mandate to the federal mandate.
Yes.
Okay, now that one seems a little harsher.
Yeah, absolutely.
So that one says no exemptions.
Correct.
Is that how it's defined to you?
Well, from what we know today, there hasn't been. We're still waiting for the details of what that will look like. But yes, that didn't provide those areas of patient care areas in terms of that federal mandate.
But did it still include the religious and medical exemptions?
I can't imagine it not. How could you force someone with a medical, contraindication to receive a vaccine, or constitutional right for religious conscience objection.
Is there a date on that?
There's
Federal
not.
mandate? No date. Okay. Okay. So Dan, clinical, how does the government not see a looming nursing shortage as a crisis that they're creating?
Deborah, as I got this question, it's like, wow. I mean, this is a question that is calling for some significant speculation. It calls for me to try to get in the heads of our leaders in this country, and that's a very scary place to go. Because as I've watched decisions come and go, and the constant ebb and flow of recommendations, if you remember back when we started COVID, it was on a daily basis, the mandates and the recommendations were changing. And it's like, when I make a change and I'm contacting stakeholders and engaging all our teams throughout the organization to predict the impact on a change that I'm going to recommend within the organization. And the government, this is me, again, optimistic, believing that I think they believe that they're doing the right thing to protect our country, to protect each and every one of us. I don't know that they fully understand the impact of their decisions. Oftentimes they're unfunded mandates, by the way. So I can't answer this question. I would like to think that they took into consideration the impact, as Ryan and you questioned, the federal mandate to totally eliminate any potential for exemptions or declinations. Many organizations will be devastated. I mean, they could lose 15-20% of their care providers, and there is no way to backfill these positions. So my short answer is I have no clue. I have no clue what they were thinking, but I would like to believe that yes, they believe they were doing the right thing to protect each and every one of us.
Yeah. So even the surveillance testing, it's been mass amounts of tests, and Ryan, your team has really handled that distribution.
Yeah.
And because how many tests have you handed out to employees?
Well, if you put on about 3,500 a week is what we're required to do. And then the distribution piece, I've got to recognize the team, Randy Coca from Lab and Ashley Verbeek and Susie Plummer and so many other people that were involved with the planning of that. But it was a massive operational, rollout to become adherent with that state mandate. So so just do the math, 3,500 a week. And so, 7,000, 14,000 a month plus, and we've really striven to keep it, to fulfill the spirit and intent of the mandate, to protect our patients and our staff, but to do it in a way that is efficient, as least intrusive as possible for our staff in an honoring way. And so I think we've accomplished that. I think we've done a great job in again, fulfilling the requirement and honoring our staff.
Okay, so talking about testing, a lot of people have been complaining about the lack of access to testing. Sometimes it's 2 or 3 days before you can get in. So what changes have we recently made to expand our capacity to testing?
Yeah, it's a great question. We've really striven to meet the community needs all along. There's a lot of multiple layers in terms of our ability to do that. And early on, it was just a sheer lack of testing kits, testing supplies across the United States. Again, Randy Coca, our director, we would be absolutely lost when it comes to testing without Randy's leadership and his ability to secure product for us to test for the community. And so when we started getting allocations, started getting our testing supplies in hand, we rapidly scaled up our ability to test. So if you recall, as a community, if you experience any of this, our urgent care is obviously very busy, but then all of our rural health clinic locations, We installed C trains out in the parking lots to just keep symptomatic people out of the clinic and keep people safe. Keep it convenient. Drive up, swab, go home. It's all telehealth visit. You get the results same day with our Sophia 2 antigen tests, which is really what the community demanded, because those molecular PCR tests typically take 40 to 72 hours to get a response. And man, you're sitting at home waiting for 3 days to know if you're positive. So we've really striven to meet that community demand. And did a good job with it. And so, but come around April, May, everything slowed down. It's like, man, I was with you. It's like, you know what? Praise God, like we've gotten through it, and here's crystal ball. We're like, guys, I don't know, it's gonna get a lot worse. It's like, this is a respiratory disease. We're in the summer, although we did have a surge in July of last year, which is very odd for a respiratory virus. But and so, we were releasing these, we were staffing it up. We didn't have hardly, every day just had literally, 20% of our, slots were being taken. And so we wound them down and we disbanded the C trains. And then this next surge comes along, and it takes about, 5 weeks to prop these things back up, to get them reinstalled, the computers, the phones, and then to hire the staff. To staff up these areas. And so I'm very pleased to say Ivan Hada and our director of Rural Health Clinic System and that leadership early on, 5-6 weeks ago, got back about the business of reinstalling the C train. So as of Monday, we more than doubled our testing capacity. If you go to the Kauai Health website and click the button on schedule a test, you'll see now 8 locations listed for our COVID testing locations. That's effective as of Monday. And those slots per location will continue to expand as we continue to hire more staff. That's one of the biggest limitations there. But so again, doubled our locations, significantly increased our testing capacity just to meet the needs of the community. We'll keep those in place throughout the respiratory season.
Okay, and now we have a phone number if they can't get through online.
Yeah. So if you have, if you can't schedule online, you don't have internet access, what have you, it's called the centralized call center at 559-592-7300, and we'll get you scheduled for a COVID test.
Okay, and we will put that phone number when we do the written transcripts. All of that information will be there. So that's great.
Yeah, we're very excited to bring that level of service back to the community.
Okay, so we're also getting a lot of comments on our social media that people are having a hard time getting their test results. They're calling many times, and so what is the time frame that people should be getting their results in?
Yeah, so when you schedule the test, you choose either a PCR or a COVID, telehealth visit, which is your antigen same-day results. So typically, you go through the whole process. It's all via the phone. Then you drive up, get swabbed, and you go back home, and you should receive the results within a couple hours of that swab, and that's the usual. Now. We keep breaking records, but in terms of number of visits to the urgent cares. So the same provider that called you is the same provider, calling you back with the results, particularly if they're positive. But that same provider is also trying to get to the patients who are waiting to get their tests ordered. And so the callback time frames can be impacted in terms of just trying to handle the sheer volume of people seeking testing. But certainly same day results, and ideally would be within 2 hours of swab. Now, if you are asking for a PCR test because you've got to get on a plane and travel internationally and you need that molecular PCR test, those tests have to be couriered over to the central lab at the hospital. They have to be resulted in batch, and that can take 48 hours or so to get that result back to you. So it really depends on the type of test and really how impacted the clinics are. Again, because we've doubled our testing locations, we really see getting back to that 2 hour time frame of getting that call back with your results. We apologize for again, those few locations we had in place at urgent care is just trying to shoulder the entire community demand has been very tough on those teams, and so we apologize for any delays in getting you your results, but we're very optimistic that now that you'll be able to get back to that 2 hour time frame.
Ryan, is there any truth to the rumors that the Johnson & Johnson vaccine is now recommending a second dose?
Yeah. So truth and lies and all that. I try to really stay away from all of that belief or what have you.
Yeah.
Yes. all vaccine manufacturers are currently testing booster doses. So again, this is a respiratory virus. This is not like polio or a virus that doesn't mutate, and a lifetime vaccine is good. We know immunity wanes, whether it's native immunity from active infection or it's vaccine immunity. We know that it wanes, and so all vaccine manufacturers are testing. What time frame is necessary, how long does immunity last from our vaccine, and so yes, Moderna, Johnson & Johnson, and Pfizer have or will all apply to the FDA for approval of a booster dose. Now, this just in, hot off the press, actually still warm, not just lukewarm, but the FDA yesterday approved the Pfizer vaccine booster dose. For those, not the third dose, which they approved prior for immunocompromised people, but the actual booster dose for, and in this initial approval, it's people 65 years and older, or those with high risk for severe disease, or those with occupational exposure like healthcare workers. The CDC, so the FDA approved yesterday, the CDC must also approve, and they met today at noon on the East Coast time. And so we should know that, and we're highly, assured that they will follow suit and approve what FDA approved yesterday. So booster doses will start rolling out here in the next week in the community, and highly recommend folks get it. I was literally, I'll share a little personal thing. I was literally like a week away from the booster. I'm eligible. I'm 9 months out. I was going to be first in line to get it, and I contracted COVID. It's about 14 days ago. But I can tell you, I can attest to the effectiveness of the vaccine. I mean, I really wouldn't have got tested unless my kids actually got sick first and got tested, and they were positive, so I went in and got tested. But literally, I mean, I just, brushed it off. My fever didn't break 99 degrees for less than 24 hours. I never had a respiratory cough. I just felt a little tired. And so, and had I had the booster, I know I probably wouldn't even contracted it. But I did and got through, and my family's all good too as well. But in the same time frame, guys, honestly, the same time frame, in the last 3 to 4 weeks, I've got 3 friends that couldn't get talked into a vaccine, younger than me, healthier than me. One spent 4 days in the hospital on oxygen, still at home recovering, off of work for a month. And then 2 others are at home right now with bilateral pneumonia and very serious, conditions. And so when I just juxtapose my personal experience being vaccinated with colleagues around me that, not colleagues, but friends around me in the community that weren't, and what their experience was relative to mine, that's not statistically significant, it's not scientific, it's just an anecdotal observation.
Well, we're very glad you're back, and we're very glad you're okay.
Good to be back,
Yeah. So just correct me or make it very clear. Are we calling it a third dose,
No.
or are we calling it a booster?
Well, we're calling it both, right? So booster, sorry.
Okay.
So remember that for on the original approval, and I'm just going to use Pfizer for example. In order to acquire immunity, it required a 2-dose series. Okay, and that was approved. What we're finding is that in certain populations with autoimmune or on immunosuppressive drugs, they require a 3-dose series to achieve that same level of immunity. And so for them, it's called a third dose. So for somebody has an immunosuppressive condition or an immunosuppressing drug, that means that it suppresses their immune system. It suppresses their immune system's ability to respond to a vaccine or a disease. And so, whereas somebody without that condition, they achieve immunity with 2 doses. That population needs 3 doses to get that immunity level high enough to protect them. Mm-hmm. So that's the third dose. The booster is, again, what I think we're going to reach is an annual booster dose for everyone, like your annual flu shot, because we know immunity wanes. And so whether you've got sick last year or whether you had the vaccine last year, in 12 months from now, you could get sick with COVID if you don't have a booster to boost your immunity to keep you safe. So that's the distinction
Yeah.
between third dose and booster.
Right, so it's kind of rolling out like it did when it first came out, Dan. Pfizer is rolling out. That's the one
Right.
we all got
Pfizer's
at the
number
beginning.
one. Mhm.
Pfizer is now with the booster.
Mhm.
You know, how far behind, because a lot of my friends and family got Moderna.
Yeah.
So they're super jealous if I get to get the booster first. But how far behind is Moderna?
Well, they've made the application
Okay.
for it, so it's a matter of going through the FDA and the advisory committees to get that approval to go ahead and say it's the third dose or it's the booster dose. Just to come off of what Brian was saying, hot off the press, and we were saying where's the CDC? So I was just before coming over here scouring the internet to try to get you the latest and greatest information, and California Health Alert Network. So they're the ones that kind of push it out for all the healthcare agencies. So they're like all facility letters, and they're giving you what they're standing behind. And they said that California supports our federal partners in the determination to provide Pfizer boosters. They use the word boosters, specifically for those, as Brian had already alluded to, 65 and older, and individuals that have significant immunosuppressing types of conditions. But they also went on to say individuals 18 to 64 years of age, it's open to them that are high risk for severe disease, immunocompromised, respiratory issue people, along with those individuals who frequent institutions or have occupational exposures that put them at high risk. So what are those individuals? How do they define those? So looking further into the internet, trying to get you the latest and greatest, the advisory board released as of today, according to the FDA Commissioner Janet Woodcock, those groups include healthcare workers, teachers, daycare staff, grocery workers, and those in homeless shelters or in prisons, among others. But those are the major groups. So based on what they're releasing today, it would be all healthcare workers that work in these settings. We would be eligible for that third shot, or if you want to call it the booster.
The booster, Dan.
It's the booster. Now I will tell you, and as Brian shared some of his personal experience with an active infection, right after my second injection of the Pfizer vaccine, I started in should we say, a trial monitoring how my antibodies were happening or how they responded to the vaccine. So right out of the gate, I was over the top, greater than 20. And then on a monthly basis, I went in for a blood draw, and we watched these antibodies reduce. Mm-hmm. And at 9 months, I was at 1.03. So the next test would have been below 1, which means I'm no longer covered. So, 6 to 9 months. Mine was 9 months out. Mm-hmm. And I no longer had sufficient antibodies to protect me. Now that doesn't mean that my body and the T cells would not respond to an infection, but that tells me that I need the booster. Mm-hmm. And
okay, so do you think we'll see booster clinics like we saw vaccine clinics, like at the Ag Center, at COS? Do you think we'll have access to it like that?
Because he's the vaccine king.
Yeah, I participate on the Tulare Kings COVID Coalition with the county and various, and Venice and various other healthcare organizations in the community. Talked openly about that. The fact of the matter is we have so much access to vaccine through the pharmacies and the various clinics, and those schedules continue to be virtually, not empty, but there's a lot of capacity in the community. And so until we see that there's really no capacity and we need to create more capacity to extend vaccinations, it's a waste of resource and people. We're all very under-resourced, understaffed. When we did the Ag Center event, we sent inpatient nurses out there. I was out there. And it was exciting. We loved to do it. And we'll do it again. if we have to. But the simple matter is that we have so much availability of the vaccine throughout the community that unless we start hearing that, man, there's no scheduled appointments available left, or we're having a hard time getting in, it wouldn't be a prudent use of resources and time to do that. Internally for ourselves, we've got several thousand employees that are eligible for the booster, and so we're talking internally how we can prop up a booster day, or a few days for our own staff to help get them expedited on that booster to get that protection. But again, we're strained with staff to even do our own little pop-up, booster clinic. But anyway, so we're talking about internally.
Okay, so
I bet you and I can
Yeah,
deliver vaccines.
we're licensed.
We're licensed.
It's true. Dan and Ryan. Sure.
yeah, so a community member is asking, how long do I need to wait to get the booster if I am currently at home with COVID?
Okay, so if you're still recovering from active COVID infection, you'd want to wait until you are fully recovered and past that 10 to 14 day window. You certainly want to be afebrile or without a fever for 24 hours and with declining symptoms, particularly GI too. But once you're fully recovered from the infection, you are eligible for the vaccine. Now, with that being said, you will have some natural immunity from the infection, but that too wanes. Again, that wanes. I know people who have had COVID more than once, and so know that active infection or vaccine, it's important that you receive that booster dose. In terms of time frame, what best time frame? I mean, I'm not speaking out of scientific, studies in terms of what's the best, how many months after active infection should you get a booster. We just simply don't have that, and it's highly individualized in terms of your relative immunity and how long it will last. So I would just recommend you to get the booster, shortly after recovery. It's not going to hurt you, and it'll certainly make you superhuman in terms of your protection. The studies that do show, the largest to date study out of Israel with over 700,000 people showed that the people with the greatest immunity are those who have a history of active infection and were vaccinated. That group have the absolute highest protection against severe disease and death. So get it. Get it when you're eligible and well.
Do you think we'll have the same side effects that we had the first two times? Some people had a fever, some people got sick. They kind of developed flu-like symptoms.
Yeah, so actually that was reported. So part of Pfizer's study that got them approved assessed the side effects of the booster dose relative to the others. And yeah, typical, right? Aches, flu-like symptoms, not true full-blown, flu-like, but the generalized fatigue, aches, a little bit of swollen lymph nodes, right? That's what happens naturally when your immune system is trying to fight something off and mounting a response. But it wasn't noted as any more severe relative to the first two dose series.
Okay, thank you. Why does the hospital consider people who have only had one dose of the vaccine as unvaccinated?
Well, it's not necessarily the hospital that makes that determination. As it relates to the state mandate, we'll start there. The state, in their mandate, said by September 30th, you have to have the full dose series. So depending on the product, right? If it's Johnson & Johnson, it's one dose you are considered fully vaccinated because that's the way that was approved and studied. But if it's Moderna and Pfizer, you're not considered fully vaccinated unless you've received the 2-dose series. And that, again, wasn't defined by Korea Health. That was the state of California, and honestly the FDA and the drug manufacturers. And so that's really where we're at in terms of how we have to consider people vaccinated or unvaccinated.
So, and we received the questions on social media. Why do we, if a patient declines to answer, we consider them unvaccinated? Why do we do that? We just assume that?
I think there's a third bucket.
Is there a declination now?
Yeah, there is. Yeah,
Okay.
we have unknown,
Okay.
unvaccinated, vaccinated, and unknown.
Yeah.
Okay,
Yeah,
all right.
that was. Remember that was asked last month.
And then,
that could go the other way too. I mean, we have no way to prove if you truly are vaccinated unless we're demanding the evidence of vaccine by your cards. And for our visitors, that's part of it, where we're saying we need to see evidence of your vaccination, or we need to see a negative test.
Or we confirm it, yeah.
Yeah, where we can confirm it.
So fully vaccinated means you've taken the recommended doses of each vaccine.
Yes.
So now that the booster's out, is that going to be part of the dosing series to where you're considered unvaccinated if you don't get the booster?
That hasn't. I mean, there's been nothing coming from the feds or the state in terms of the mandates and as it relates to the booster. Again, it was approved yesterday by the FDA and probably by now the CDC has approved. But policy and mandates lag behind. Again, I think on the long view, what we're looking at is the annual booster shot, like an annual flu shot.
Okay, thank you. So Dan, why are we not prescribing ivermectin here at Kauai Health?
Well, what do you think, pharmacist? I can answer that.
Repeat the question. I'm sorry.
No, I'll take that one.
No,
Don't worry, it's the ivermectin.
Oh, right.
It's our ivermectin.
Did you tune me out? Do you have COVID brain, right?
No, I do.
It
Honestly,
probably does. What I did is, I've heard it. It's being used out in the community intermittently. Why isn't ivermectin one of those frontline drugs? I mean, simply put, if you go by the meta-analysis studies that are out there, and I looked at, I googled meta-analysis studies ivermectin. I went into UpToDate, which is a resource that we use as medical providers, that I use as a medical provider. So it gives me all the latest information relative to treatment parameters for diseases. So, I heard about it, and I know people are using it anecdotally. I don't prescribe it. In an outpatient basis, it would be used for outpatients. But simply stated that there is the quality of evidence for these outcomes, meaning mortality and mechanical ventilation and the impact on symptom resolution in the United States, it's deemed to be low or very low. So as such, there is no support when we look at the risk bias and the risk versus benefit of using the medication. Now, again, anecdotally, I've talked to some providers. I won't name these providers, but they say it works. And Ryan mentioned a meta-analysis study. It was Israel, I believe. And if you Google some of these analysis studies and you read these over in Europe, they are finding that it works. However, the FDA has a very high standard before they're going to say, we support this. But also, medical providers have the opportunity or the option to use a medication off-label. So what does that mean? It means I can use a medication that is specified for this over here, even though it's not specified. And it's the clinical decision-making of that provider to say, the risk-benefit, as I deem it, says this is okay to use. So why we don't use it is it's not approved through the Food and Drug Administration.
And I can
Go ahead.
add a little shade to that. As part of the employee huddle last month, or a few weeks ago, that was also a question that I was asked to answer. And so I did a fair bit of amount of research. And as a clinical pharmacist, right, I read those studies, very carefully. The ivermectin studies, there was 14 that I could find, and there might, again, data's coming in every day. So I don't know, there might have been another study that was published between now and then, but the vast majority of studies, all the studies were very small, poorly controlled or designed in a way. They were all retrospective reviews mainly. They weren't double-blind, placebo-controlled trials. The populations, including these studies, range from 14 patients to 66 patients, 74 patients across the world, some in Argentina, some in Brazil, some in the Middle East, a couple in the United States. The largest study was in Argentina, had over 500 patients included, and that was an inpatient study. They actually studied ivermectin in inpatient use, so severe disease, right, and ventilated, and actually that showed that it had increased mortality with ivermectin on the inpatient use. Outpatient studies is a mixed bag, but when you have studies that are fairly poorly designed and powered and small, you're going to see like, oh, this one worked, and this one didn't work, and so there's just no objective, ability scientifically to say yes, ivermectin works, and we should give it to everybody. I would love to see a much better, larger trial that would really help us understand whether or not it works or not. Because you hear a lot of anecdotal stuff. Friends are constantly just sending me YouTube videos of some physician standing up in some school board. If we just gave ivermectin to everybody, we'd be, eradicating COVID. Everyone wants a silver bullet, right? Everyone wants the answer, how we're going to get past this. And if ivermectin is it, I would be the first in line to take it. But just the objective scientific evidence isn't there yet.
Yeah.
So.
I mean, look at it. We're almost 2 years into a brand new disease, and we're still working on multiple angles to try to figure out how do we save these people from hospitalization? How do we save these individuals who get into the ICU that never make it out of the ICU? What is the silver bullet?
Yeah.
We're still figuring that out.
And this isn't a massive conspiracy that we're trying to suppress this cure for the disease. Believe me, it's not the case. I mean, ivermectin is an awesome drug. It won the Nobel Peace Prize. This drug, though, is an anti-parasitic, right? I mean, it's designed to kill parasitic worms. It's not an antiviral. But drugs have what we call pleiotropic effects. They have effects beyond their intended use that we don't fully understand. And so we know it has some in a test tube. It demonstrates antiviral properties, but in that test tube, the concentration that I can put in that test tube is literally 100 times the concentration of what I can achieve in a human lung. And so just because you can prove something in a test tube in vitro does not mean you're going to get the same result in vivo, in life, in living organisms. Can the human body take a dose 100 times the normal dose of ivermectin to achieve that concentration without dying of an arrhythmia or getting some other crazy side effect because you just have 100-fold concentration of the drug in your body? So it's very complicated to go from in vivo to in vitro to in vivo, and it's a big leap, and the human body is very complicated. So I can go on and on, but
but just one final comment on ivermectin and what I did as I was reading quickly through all these research studies is what they did find is very poor outcomes and death even when an individual goes out and picks up ivermectin on their own and takes it. So,
that is going to feed supply stores and buying ivermectin off the shelf that's intended for horses. Or cows and ingesting again that incredibly high concentration and dose of a drug is dangerous, and again not proven effectual. I have friends that I took some ivermectin, not great, odds are most people recover from COVID just fine. So was it ivermectin that did that, or was it just your natural immunity that fought off the disease like most people? So
more to come.
Yeah, more to come. And we are a healthcare organization. And if we could come up with the magic drug that got rid of COVID in our area, you bet we would be in line for it. But it kind of goes right into the conspiracy theories that we like COVID because we're rolling in money.
Yeah.
And that we're still on social media battling. I still battle that out in the community.
Same.
People are like, well, yeah, it's in your best interest to have COVID because you guys are making so much money. Now, these are community engagement people. They have been with us since the beginning. So we've talked about our budget. We've talked about
the impact.
Impact. So, but for our social media world, do either of you have anything to say about the claim that we are just rolling in money?
We, on average, for a COVID admission that requires ventilation in the ICU, right? Very serious condition. Most of our highest, beyond surgeries, costing cases are critical care cases. because of the intensity of care that's required. So on average, we receive about $50,000 reimbursement. Now, there's so many variables that dictate the amount of reimbursement, who you're insured by, Medicare, Medi-Cal, private insurance, uninsured. All of that has huge variation in terms of what we are reimbursed for the care we provide. And then other comorbid conditions, right? You come in with COVID and COVID alone, or you come with COVID and had a stroke, or, so depending on what we call comorbid, or the other conditions that you have at the same time that we're treating, all these different conditions, affects how much we get paid because we have to provide more services. But on average, when you look at across the deck of COVID admitted cases on ventilators, we get reimbursed about $50,000 a case. When we look at our direct costs and indirect costs to provide care for those patients, it's about $64,000. So we lose $14,000 for every patient that we treat on a ventilator with COVID. So no, we lost over $4 million last month. We've shut down elective surgeries, which is really, again, the financial engine of any major hospital system. And why do we do that? To afford more beds to treat COVID patients that we lose money on every patient who walks in the door. So, we're a public entity. We're a nonprofit. We're owned by you, the people, and we're here to serve you, and we're doing it, and we're doing it at a great cost, and we need to stay financially viable, and we're not today as things continue to stand. And so we are absolutely dependent upon any federal state subsidies that can help us pay the bills, because we're not doing that today.
Okay, before we close this out, we do have a question. First of all, we have a statement, and it's that I took my dad for COVID testing on Monday. We got the results back in less than an hour. The overall process was very efficient.
Thank you for commenting on that.
Yeah. And then our final question. How do you feel about the vaccine for older kids, say 14, 15? How do you feel about that?
I think it goes right. It's just like the influenza vaccine. I mean, the vaccines work, and the more we can get our children vaccinated against this virus, it just increases the immunity in the community. How's that for use of words? Mm-hmm. But I believe in it, and I've got grandkids. Of course, only 2 of them fall in the range. The others are much younger than that. But we vaccinate our kids when they're born, and moving into a grade school. They're getting vaccinated against illnesses, viruses that have been eradicated. And why? Because of vaccinations. We know that vaccines lessen the disease process, or makes it easier for us to recover, prevents a lot of us from hospitalization. As Ryan has suggested, he felt like he just had a cold, but he was positive for COVID. A lot of people, they think they just have a sinus infection, but they've already been vaccinated. They've had the series, the 2, and it works. And the prevalence of COVID illnesses in the children is quite high now.
Yeah, I know we're running up on time. As a clinical pharmacist, don't be the first, don't be the last, is always kind of this motto when a new drug comes to market, because it can take time to demonstrate, with post-marketing surveillance in terms of safety and efficacy. COVID vaccine, though, over 3.2 billion people have received the vaccine. Millions of children have received the vaccine. So safety and efficacy data, we're getting what would normally take years to really come I don't know. We know in months. And so we understand that COVID is kind of like inverse of polio, right? Polio was like, protect the kids. They're the ones who get impacted by COVID the worst. It's inverse of that with COVID. It's the frail, it's the elderly, it's the comorbid condition adults that tend to have the more severe reactions. But kids are carriers, right? Kids have grandparents and great aunts and uncles they visit. And so for the safety of them and the vulnerable in our population, it's important that we achieve herd immunity. Concerns about infertility or those types of issues. And again, not using the word belief, but just looking objectively at the data, it's not there. there are tens of thousands of cases around the world of people becoming pregnant, having successful, healthy pregnancies and deliveries, having been vaccinated. There is no evidence that the vaccine causes spontaneous abortion or sterility, but there is, ample evidence of the dangers of active COVID infection and what happens with the gross inflammation of the lung tissue, the placental lining, and so risk to the developing fetus and risk to the mother if you contract the COVID vaccine during pregnancy. And so, again, I try to stay very objective. I try to just look at the data as it comes in. And so, yeah, I as it stands today, I support it as it is studied and approved.
All right. Well, thank you both so much for joining us. I appreciate you taking the time to come over and be in our studio and answer the questions. It's always good to see you, and thank you so much to our online audience.